Hello, I'm Jim Caridi. I'm a professor at Tulane University Medical Center, and I'm here to talk about transcatheter therapy, how I do it. Well, the first thing we have to do is assess the patient, and in this case, the patient's a 59-year-old male with multifocal bilobed hepatocellular carcinoma, has an ECOG of 1, Child-Pugh of A, hepatitis C etiology cirrhosis. His liver labs are unremarkable, his creatinine is normal, he has no biliary enteric anastomosis, and he has no previous therapies for hepatocellular carcinoma. This is the CT scan that was performed, and as you can see, he has multiple large, multifocal, bilobed hepatocellular carcinoma, and considering the size and number of the lesions, he is not a candidate for either the Milan or UCSF criteria. So what do we do for this patient? Well, considering the extensiveness of the disease, two things that are possible are either Y90 or drug-eluting beads. In this case, we decided to go with the drug-eluting beads. So how do we do it? Well, we start with the three-phase CT scan, which obviously diagnoses the patient, but looks at the number and size of the lesions. We look at the arterial supply, the anatomy, whether there's extrahepatic supply, aberrant vessels, AV shunting, portal vein involvement, or extrahepatic disease. We assess the patient clinically. What's his ECOG status? Bilirubin, albumin, AST, ALT, INR, and sometimes MELD, platelets, and creatinine, and if he has a biliary enteric anastomosis or not. And this will determine whether we use antibiotics or not. We tend to use antibiotics if there is an iatrogenic biliary enteric anastomosis, and we don't if there's not. I use a 4 French catheter alone in about 80% of the cases without a sheath, which allows the patient to not have a closure device and also to ambulate after 2 hours. We use a microcatheter in every case because it can get close to the lesion, it reduces the incidence of spasm, and most importantly, it maintains flow so the beads can get to the objective site. In some cases, we have to use DynaCT for the patients who have those disappearing lesions. We use 3D delivery, which I'll explain, and we go to near or total stasis. And in some cases, as in this gentleman, we may use sorafenib. Now we talk about 3D delivery, and what that is, it's dilute. What we do is we dilute 5 to 10 to 1 to the cc of drug-eluting bead, so that it's more readily can go to the area of involvement as opposed to stacking up proximal or central to where we want it to go. We use delayed delivery in that we wait in between injections and we deliver slowly. It suggests that you do a milliliter per minute or slower and then wait after the injection, and of course it's deliberate. We make sure that we're doing it precisely each time, and we watch what we do, and when we're done we wait and see if there is any increase in the amount of flow. Okay, so when we talk about 3D delivery, what we're talking about is here are the beads, and what we do is we connect to a 3-way stop cut, and we dilute at least 5 to 1. Now, you can trade this syringe here for a 3 or 1 cc depending on what you like. We use a medallion 3 cc syringe when we're using a microcatheter because it's easier to inject. And then this is a catheter we usually or typically use. In 80% of the cases we can do this sheathless. It's just a SOT 0, which can be used to do preliminary work and also some sub-selective work if necessary. And just attach. And again, it's slow delivery, it's deliberate delivery. And you wait, you do it again, reassess, because with the closure of smaller vessels, other ones will open up, and then you can advance and get more beads into the area of interest. Also with the dilution, there's less premature occlusion. In this patient, considering the extent of disease, we used lobar technique. The right lobe was treated, and after 3 to 4 weeks, the liver enzymes were evaluated, and determined to be within normal limits. And the second lobe, the left lobe, was then subsequently performed using the same 3D technique, period. This CT scan is the result of bilobal treatment with a follow-up 1 month after the second treatment. And you can see that the hypervascularity is almost entirely absent.